Welcome back to StudyNeuro. In this video, we'll be discussing the complications of the Mayfield Head Holder. This device is indispensable for rigid cranial fixation and has transformed neurosurgical precision and safety. However, despite its benefits, it can occasionally lead to rare but serious complications that every surgeon, resident, and trainee must understand. For a detailed breakdown of the device's parts, functions, and principles of application, be sure to check out our earlier video on the StudyNeuro channel. Complications with the Mayfield Head Holder usually stem from pin placement, the amount of applied force, patient-related vulnerabilities, or even device malfunction. They are generally categorized into 5 groups: skull and intracranial, vascular, soft tissue and scalp, neurological, and device-related complications. Among these, the most commonly reported are epidural hematoma, depressed skull fracture, and venous air embolism. Complications with the Mayfield Head Holder are influenced by patient, skull, technical, and anesthetic factors. High-risk patients include children under 6 with very thin skulls, the elderly with osteoporosis, and those with conditions like hydrocephalus, renal osteodystrophy, or metabolic bone disease. Fragile bone areas, unfused sutures, prior craniotomies, or regions overlying sinuses add to risk. Technical errors, like excessive torque, wrong pin angle, or pinning near vessels and nerves, also contribute. Anesthetic factors, such as poor analgesia during pinning or use of the sitting position, further increase complication risk. Patient-related factors significantly influence the risk of complications with the Mayfield Head Holder. In children under 6, the very thin skull makes them prone to depressed fractures and epidural hematomas. The elderly with fragile or osteoporotic bone face similar risks of fracture and poor fixation. Hydrocephalus with thinned calvaria increases susceptibility to fracture and pin penetration. Chronic kidney disease and metabolic bone diseases like rickets or osteoporosis result in brittle skulls, raising the chance of depressed fractures and device instability. Long-term anti-epileptic use weakens bone, again predisposing to fractures. Patients with vascular lesions, such as aneurysms or AVMs, may suffer catastrophic rupture from hypertensive responses. Those with high vagal tone are at risk of severe bradycardia or asystole due to the trigeminocardiac reflex during pin application. School-related factors also increase complication risks with the Mayfield Head Holder. Thin or fragile bone in children, elderly, or hydrocephalic patients predisposes to depressed skull fractures and epidural hematomas. Unfused sutures in infants and young children can separate under pressure, causing instability. Previous craniotomy sites, burr holes, or hardware like shunts and Ommaya reservoirs weaken bone and increase the risk of penetration or hardware damage. Areas overlying sinuses, frontal, mastoid, or lambdoid, carry risks of dural tears, sinus injury, and bleeding. Finally, congenital skull defects or cranial dysplasias create structurally weak points, again raising the risk of fracture, penetration, or poor fixation. Technical errors are a key source of complications with the Mayfield Head Holder. Excessive torque can cause depressed skull fractures or epidural hematomas, especially in children. Incorrect pin angle leads to skiving and clamp instability, risking loss of fixation. Placing pins too close to superficial arteries or nerves can result in laceration, bleeding, or neural injury. Poor preoperative planning, such as failing to check bone thickness or sinus location, increases the chance of penetration, sinus injury, or inadequate fixation. From an anesthetic perspective, inadequate analgesia during pinning may trigger hypertensive surges, bradycardia, or the trigeminocardiac reflex. The sitting position further adds a risk of venous air embolism due to negative venous pressure at pin sites. Skull and intracranial complications are some of the most serious outcomes of Mayfield Head Holder use. Skull fractures are the most frequent, and they can be depressed, displaced, or linear.
These are more likely in pediatrics, elderly patients, or those with hydrocephalus and bone disorders like osteoporosis or renal osteodystrophy, where the calvaria is especially thin or fragile. Epidural hematoma is another important complication, often associated with a fracture or direct penetration of the inner cortex by a fixation pin. This can result in acute neurological deterioration if not promptly recognized. Though rare, intracerebral hemorrhage has also been reported, likely from deeper penetration or vascular injury during pin fixation. If the frontal sinus is violated by pin placement, patients may develop cerebrospinal fluid rhinorrhea, with the added risks of meningitis or persistent CSF leak. Finally, tension pneumocephalus may arise when a CSF leak combines with negative pressure, allowing air to be drawn in through the pin site. This trapped intracranial air can lead to significant neurological compromise if unrecognized. These complications highlight the importance of careful patient selection, pin placement, and preoperative imaging review. Mechanical and device-related complications, though rare, must be kept in mind. Clamp breakage can occur due to fatigue fracture of the metal components or defects in the locking mechanism. Fortunately, most of these incidents are recognized quickly and rarely cause direct patient harm, but they can disrupt the procedure and compromise head stability at a critical moment. Scalp and soft tissue complications are more common. Pin sites may cause scalp lacerations, particularly if excessive torque is applied or the skin is thin and fragile. Subgaleal hematomas can develop beneath the scalp from bleeding at pin sites, which may cause swelling and discomfort. Patients may also experience local pain at the fixation points and, in some cases, small postoperative scars. While these soft tissue complications are usually minor compared to intracranial ones, they still affect patient comfort, recovery, and cosmetic outcome.
Vascular complications, though uncommon, can have serious consequences if not promptly recognized. For instance, injury to the middle meningeal artery during pin penetration may lead to an epidural hematoma, a potentially life-threatening condition requiring urgent surgical evacuation. Similarly, damage to the superficial temporal artery can cause significant bleeding at the pin site, or, in rare cases, lead to the formation of a traumatic aneurysm, which may present later as swelling or a pulsatile mass. Another important vascular concern is venous air embolism, which occurs when pins inadvertently penetrate venous sinuses or emissary veins. The risk is greatest in the sitting position, where negative venous pressure favors air entry. Venous air embolism can cause sudden hemodynamic collapse and must be recognized early to prevent fatal outcomes. While vascular events are less common than skull fractures or soft tissue injuries, their potential severity makes careful pin placement, vigilance, and intraoperative monitoring absolutely essential. Venous air embolism, or VAE, is one of the most feared vascular complications of the Mayfield Head Holder. It results from pin penetration of non-collapsible venous channels, such as emissary veins or venous sinuses, creating a direct route for air to enter the venous system. The risk is greatest when the patient is in the sitting position, but it can also occur during clamp removal or after multiple pinning attempts. Detection is critical. The precordial Doppler ultrasound remains the most sensitive monitoring tool, able to detect even small amounts of air. Anesthesiologists may also observe a sudden drop in end-tidal CO2, and in some cases, air can even be aspirated through a central venous catheter. Management requires immediate action: sealing the pin site with bone wax, repositioning the patient into Trendelenburg, and aspirating air through a central venous line. Supportive measures such as hemodynamic stabilization are also essential. Although rare, VAE underscores the importance of meticulous technique, prevention strategies, and close communication between the surgical and anesthesia teams during head fixation.
Neurological complications from the Mayfield Head Holder are less common, but clinically important. One of the most dramatic is the trigemino-cardiac reflex, which occurs when pinning stimulates the trigeminal nerve or its branches. This can trigger sudden parasympathetic outflow, leading to severe bradycardia or even transient asystole at the moment of pin insertion. Prompt recognition and immediate withdrawal of the stimulus, along with atropine if necessary, are crucial to prevent cardiac arrest. Another concern is direct nerve injury. Placement of pins too close to the supraorbital, supratrochlear, or occipital nerves can cause temporary or permanent sensory deficits, manifesting as numbness, tingling, or neuropathic pain in the corresponding distribution. Equally important are the hemodynamic responses during pin application. If local infiltration or systemic analgesia is inadequate, insertion of the pins can provoke a sympathetic surge. This manifests as abrupt hypertension, tachycardia, and sometimes arrhythmias. The consequences of such a response can be serious, particularly in neurosurgical patients. A sudden rise in blood pressure can increase intracranial pressure, precipitate aneurysm rupture in patients with vascular lesions, or destabilize those with fragile cardiac status. Therefore, careful pre-infiltration of pin sites with local anesthetic, combined with appropriate anesthetic depth, is essential to minimize these risks. Anticipation and coordination with the anesthesia team are key to ensuring patient stability during this critical step. While complications from the Mayfield head holder can be serious, most are preventable with careful planning and technique. The process begins preoperatively with thorough imaging review. CT scans can help identify thin calvarial regions, frontal sinus extension, previous fractures, implants, or hardware that must be avoided. This ensures that pin sites are chosen on the strongest and safest bone. Meticulous site selection is essential. Pins should never be placed over the temporal squama, mastoid air cells, frontal sinus, open sutures, or directly over venous sinuses. Instead, areas of thick cortical bone, such as the parietal region, should be preferred. Equally important is force calibration. Standard torque for adults is about 60 pounds, 27 kilograms, with a maximum of 80 pounds, 36 kilograms. For children, especially under 6 years of age, torque must be much lower, and specialized pediatric pins with a broader tip should always be used to reduce the risk of penetration or fracture. Torque-limiting screwdrivers can greatly improve safety by preventing excessive force. Intraoperatively, the surgical team should monitor pin sites closely for bleeding, instability, or signs of scalp compromise. Postoperatively, inspection of pin wounds is equally important to detect hematoma, infection, or delayed wound healing. Ultimately, prevention relies on combining anatomical knowledge, patient-specific adjustments, and strict adherence to safe torque and pinning practices. These measures not only minimize complications, but also enhance surgical precision and patient safety. As we wrap up, let's reinforce the key takeaways. The Mayfield head holder remains an essential tool in neurosurgery, providing rigid cranial fixation that enables safe and precise operations. But it is not without risks. Complications can arise from mechanical failure, vascular injury, or neurological responses. And while rare, they can be serious. The best safeguard is a combination of knowledge and technique. This means understanding patient-specific risk factors, choosing safe pinning zones, applying the correct torque, and anticipating complications before they occur. Proper training and close supervision are especially important for residents and early career neurosurgeons. Ultimately, careful planning and meticulous technique transform the Mayfield head holder from a potential hazard into a reliable ally for achieving safer surgical outcomes. For more neurosurgical insights, don't forget to follow @StudyNeuro. Please like, comment, share, and subscribe to the channel, and stay tuned for more focused videos designed to strengthen your neurosurgical knowledge. Thanks for watching.